Hello everyone. So I was going to post all of chapter 15 at once, but I'm going to start with module 1 because I am just starting to get the hang of this recording thing. So I'm going to go ahead and record module 1 and then hopefully it works out, and from there I might record the rest of the chapter together or module by module, just to kind of keep track of how we're doing. So chapter 15 is on psychological disorders. I am going to be cutting a bit of content from this chapter and the next chapter because we only have 2 weeks of classes left instead of 3. So this past week was treated as a reading week. We're not allowed to give you any extra material for it, so we basically only have 6 hours of class time left to finish these 2 chapters. So, your final exam as of right now is going to take place online. So it's going to basically be right through your Moodle quiz page, and it'll pop up on the bottom of the page, and basically you'll go in at a specified time and you'll have an hour, 2 hours, whatever it is, to complete multiple choice questions. So we won't have any short answer on our final, so all of the questions for these 2 chapters are going to be multiple choice only. So to get started in talking about psychological disorders, when people who think of mental illness, they often think of people who suffer from delusions or who behave in bizarre ways. However, most psychological problems are far less dramatic than the general public might believe, and they're also far more common. So I've heard a lot of different numbers thrown out there, but it seems to be somewhere around 1 in 4 people at some point in their life will experience some symptoms of a mental disorder. So this chapter will examine both the milder forms of psychological disturbance as well as the much more severe disorders, and we'll also discuss why it can be so hard for psychologists and psychiatrists to agree on a diagnosis. One of the most common worries that people have is, am I normal? In reality, it's normal for us to have problems. The difficulty is determining when those normal problems cross into abnormal ones. So we'll talk a bit in this first section, basically about issues that we face as clinicians with diagnosis. And a little bit about some of the tools that we use to help us diagnose mental disorder. So Module 15.1 is about defining and classifying psychological disorders. So in this module, we're going to talk about defining abnormal behavior and some of the ways that we've come up with to help us diagnose what could be considered a mental disorder. So over the past millennium, our understanding of psychological illness has come a long way. In the Middle Ages, for example, people who would now consider mentally ill may have been viewed as possessed, and treatments, and I say treatments with air quotes, for mental illness were directly based on this model of illness. So brutal imprisonment, torture, and even demonic exorcism were some of the techniques that people used to try and help treat mental illness. Thankfully, times have changed, and the ascension of scientific thought caused explanations to shift from demonic possession to physical illness. So at this point, we're able to view mental illness as more closely associated with physical illness rather than as a result from something evil. And so asylums, which were residential facilities for the mentally ill, were set up across Europe. The general goal was to cure whatever bodily affliction gave rise to the patient's symptoms, but many techniques were still questionable and generally ineffective. So they had come some way from kind of having that idea of demonic possession, but there was still a long way to go in terms of finding treatments that were more effective and allowed people to kind of reintegrate into society. So a fortunate change in society's approach to treating mental illness was brought about by Philippe Pine and Dorothea Dix. They advocated for moral treatment, which led to patients being treated with kindness and decency. But unfortunately, there were still few effective treatments. So at this point, they basically were trying to ensure that people who were living in asylums were treated with respect. They were allowed to, have their own autonomy in a lot of ways and go outside and enjoy things. They weren't being subjected to, cruel and unusual treatments. But there still wasn't a cure for mental illness or an effective treatment to help treat the symptoms. So by the 1950s, approximately 66,000 Canadians were living in psychiatric hospitals, but in 1955 things began to change. A drug named chlorpromazine was introduced, and suddenly even people with severe psychotic illness were able to function independently. So it was able to help people with schizophrenia and some of the more severe mental disorders actually function and kind of reintegrate into society. The success of this and other medications led to widespread deinstitutionalization, which is the movement of large numbers of psychiatric inpatients from their care facilities back into regular society. So at this point, they were able to kind of successfully reintegrate a lot of these patients into society. Unfortunately, deinstitutionalization also had its downsides. Many former inpatients quit their medications and slipped back into their disorders when they weren't being monitored. But unfortunately, helping people reintegrate into society was not a central part of the psychiatric approach to treating mental illness, which was kind of the main focus of that time. Instead, this approach was based heavily on the medical model, which sees psychological conditions through the same lens as Western medicine tends to see physical conditions. So as a set of symptoms, causes, and outcomes, with treatments aimed at changing physiological processes in order to alleviate symptoms. In recent years, the medical model has given way to what we call the biopsychosocial model, which views disorder as a result of multiple interacting systems. So this is something that we've talked about multiple times throughout this course and the last course. The fact that the majority of things we talk about in psychology, we define not only from a biological perspective, but also from a psychological and a social standpoint as well. All those factors kind of interact together. So this table here just basically shows you some of the biological, psychological, and sociocultural factors and how they influence both physical and mental disorders. So for example, biological, we have genetic influences on pancreatic function, excessive refined sugars, those types of things could influence a physical disorder like diabetes. For major depression, we have things like genetic influences on neurotransmitter production and function, sleep disruption, and lack of positive emotional arousal. So you can see that even though one is a physical disorder and one is a mental disorder, they both have some biological factors that influence them. In terms of psychological, diabetes can be influenced by poor food choices, sedentary lifestyle, and alcohol abuse, whereas major depression can be influenced by negative self-concept, pessimism, negative life experiences. So you can see how psychological factors can influence both physical and mental disorders in that respect. And then finally, you can see that there are some social cultural factors that influence both diabetes and major depression as well. So you can see that what we're doing is literally looking at a disorder through a biological, psychological, and sociocultural lens to help kind of explain its onset and the prevalence and the treatment of the disorder. So if we want to ask the question, what is normal behavior? One of the trickiest problems in the mental health field has been determining how to reliably identify who has a mental disorder and who is simply exhibiting abnormal behavior. The key criterion used by psychologists to decide whether a person has a disorder is whether the person's thoughts, feelings, and behaviors are maladaptive. So maladaptive means causing distress to oneself or others, impairing day-to-day functioning, or increasing the risk of injury or harm to oneself or others. However, there are some exceptions to these guidelines. So for example, people are considered psychopaths. They tend to have very shallow, if any, emotional responses. So that's probably not going to, their behaviors are probably not going to cause them any distress, where it says causing distress to oneself. People in mourning, if they're mourning the loss of a significant loved one or someone who is very important to them, then that's probably going to impair their day-to-day functioning, but doesn't necessarily indicate a disorder. So maladaptive kind of patterns of thoughts, feelings, and behaviors are indicative of disorder, but they don't necessarily guarantee that there's a disorder there. And also, some disorders might not really show some of these maladaptive patterns. So I put a little asterisk by the title of this slide and the next slide. These are things that are I kind of left in here from the old text, so they won't be tested on, but I just wanted to keep them in here because I think they go along really well with this discussion. So one issue with defining the term mental disorder is determining whose point of view we should take. That of society, so are we going to regard that person as troubled? Those affected by the troubled individuals, so the family members and friends of the affected person, or the perspective of the troubled individual themselves. So there are three different kind of points of view we can take when trying to assess whether or not somebody might be suffering from a disorder. The first is mental disorder as a violation of cultural standards. So this emphasizes the rules and roles of the culture that the person lives in. So many rules might be specific to a particular time or a particular group of people. So for example, if you have somebody in North American culture who is saying that they're seeing visions of somebody and is coming to talk to them, we might consider that a sign of mental disorder, whereas in some cultures it's totally normal to have visions of people, especially people who have passed, who meant things to you, have visions of those people kind of coming and talking to you and things like that. So in that culture, it wouldn't necessarily be considered indicative of disorder. The second is mental disorder as emotional distress. So in terms of the person suffering, behavior is deemed unendurable or upsetting. Behavior that is deemed unendurable or upsetting for some may be normal for others. So we should be looking at the amount of emotional distress it's putting on the person who's having to deal with it. And then finally, mental disorder as a behavior that is self-destructive or harmful to others. So this is basically emphasizing the negative consequences of a person's behavior, and so behavior that may be harmful to the individual sufferer or may be disruptive or dangerous to others. That's something that we should take into account when attempting to define whether or not somebody is suffering from a mental disorder. So our definition, and again, this is also kind of from the old textbook, but I still think it's really important information. We could say that mental disorder is defined as any behavior or emotional state that causes a person to suffer, is self-destructive, seriously impairs the person's ability to work or get along with others, or endangers others or the community. So by this definition, many people are going to suffer some type of mental health problem over the course of their lives. Nationwide surveys in the US have found that only 7% of the population suffer from seriously debilitating mental illness, but that nearly half temporarily fall prey to severe anxiety, depression, drug abuse, or other problems at some point in their life. So nearly half of people are going to be exhibiting some of the symptoms characteristic of disorder at some point in their life. In Canada, mental disorders are actually listed as the leading cause of disability in people aged 15 to 44. So that's a pretty substantial chunk of the population. So in terms of how to diagnose psychological disorders, the attempt to develop an adequate system for diagnosing mental illness goes back to at least 1840, and by 1917, a guide for mental hospitals called the Statistical Manual for the Use of Institutions for the Insane had been written. So they basically came up with this book that was meant to be used as a guideline for mental hospitals and asylums to help them treat their patients and diagnose their patients. In 1952, the American Psychiatric Society created the Diagnostic and Statistical Manual of Mental Disorders, which is a standardized manual to aid in the diagnosis of disorders. And the book's first edition described the symptoms of 106 different mental disorders. So the purpose of developing this manual was to provide mental health workers with a reliable method for diagnosing mental illness, and it was rooted in a psychobiological view, meaning that it was kind of coming from more of a medical perspective, focusing on the biological things that may be influencing symptoms. So the DSM, which is often referred to as the Bible of Psychiatry, is very important in both psychology and psychiatry, so it's used by clinical psychologists but also by psychiatrists. It aims to provide clear diagnostic categories so clinicians can accurately identify, study, and treat mental disorders. Disorders are clustered into the following chapters. So they have neurodevelopmental, emotional, somatic, externalizing, neurocognitive, and personality disorders. The DSM has had an extraordinary impact worldwide. The first edition, as I mentioned a little bit earlier, had 86 pages and 106 diagnoses. The current edition has 947 pages and over 400, or just under, I think, 400 diagnoses. So in order to aid diagnosis, the DSM describes 3 important pieces of information for each disorder. It describes a set of symptoms, the etiology, which means the origin or causes of those symptoms, and a prognosis or a prediction of how the symptoms will persist and change over time. However, the DSM is not perfect. It's received a great deal of criticism over the years. The diagnostic process is very subjective in itself, and although the DSM offers lists of specific symptoms that are indicative of certain disorders, this doesn't entirely solve the problem. For example, a clinician still has to subjectively determine if a patient is exhibiting a symptom and whether or not it is severe enough to be considered symptomatic of a disorder. So making the choice as to whether or not they even see that symptom being exhibited and if it's severe enough to warrant kind of diagnosis of a disorder, those things are still kind of subjective decisions that need to be made. Another problem is that different disorders often share many common symptoms, so two clinicians might make different diagnoses of the same patient. An additional weakness of the DSM is that there's a very fine line between whether a person is considered to have a disorder or not. So for example, there might be, you need to have 5 of these 8 symptoms to be classified or diagnosed with major depressive disorder, and you have somebody who has 4 symptoms and they're feeling them really intensely, but you can't technically make the diagnosis because they don't have that 5th symptom to kind of fit the bill. So it's a very fine line for us to be able to say, if this person has 4 of these symptoms and they're very extreme versus this person has 5 and some of them are milder, how do we kind of draw that line as to whether or not we should diagnose? The DSM also, by definition, implies that disorders can be objectively defined, which has potentially contributed to the stigmatization of mental illness. So if people view disorder as something that you can kind of get, just like they might think of a physical illness, a virus, or a cold, that kind of increases that sense of stigmatization and viewing people as kind of different from us and something you might be kind of afraid of catching, which is ridiculous, but unfortunately the way that some people think. Finally, there have been issues presented concerning giving mental health workers more labels to diagnose clients with, because it's not necessarily a good thing and may lead to overdiagnosis at times. For example, ADHD is a disorder that has been overdiagnosed at an alarming rate in North America, and a lot of that is probably due to the fact that when teachers and family members and doctors are trying to look for something to blame for a kid's behavior, a lot of the time they kind of skip to that diagnosis because it's that easy, readily available label that we have. So the boundaries between normal problems and mental disorders are fuzzy, and they can often be difficult to determine, and many psychological symptoms fall in a continuum from mild to severe. So like we said, it's kind of hard to determine whether or not somebody should be classified as having disorder in a very objective way. However, when the manual is used correctly and diagnoses are made with valid objective tests, the DSM is believed to improve the reliability of diagnosis. So if it's used in conjunction with in-person interviews and other objective tests, measures, inventories of different symptoms, then it does help improve the reliability of diagnosis. So there's a lot of issues with it, but it is an important tool for us to have. In terms of labeling in mental disorders, diagnosing a person as having a particular disorder can be seen as helpful. It's hoped that by receiving a diagnosis, it'll make people more likely to seek and receive effective treatment, and it should help facilitate communication between mental health professionals. So people who are kind of on the same care team for a person, knowing that that person has a diagnosis, that can help them kind of view the person, treat the person in a standardized way. However, diagnostic labels can also have their drawbacks, such as biasing how people will subsequently interpret the person's actions or experiences, or changing how people feel about themselves. So kind of creating a self-fulfilling prophecy. If somebody is diagnosed and their perception of that particular disorder is negative, and they think that it's going to kind of dramatically impact their functioning and their ability to, make friends and function in day-to-day life, then that may in turn kind of turn into that self-fulfilling prophecy, and they might experience even more negative aspects of the disorder. In a very interesting and daring study in the early 1970s, 8 people who were volunteering with David Rosenhan decided to get themselves committed to a psychiatric hospital on purpose. So basically what they did is they went to the psychiatric hospital and they started complaining of hearing voices and things like that, and because that's such a kind of marked hallmark symptom of schizophrenia, they were all diagnosed and committed to the hospital. And once in the hospital, they basically returned their behavior just to normal. They never once reported any of those symptoms again, but it still took some of them days and weeks to get themselves released. Even though they went to the staff and said, you know what, I'm fine, there's nothing wrong with me, just because they had that diagnostic label applied to them, the staff didn't trust them. They saw them in a particular light, and that's all that they were able to see about that person. So their experience illustrates how often we judge a person's behavior through the lens of their diagnosis. So even though they didn't exhibit any more symptoms after that initial interview, it still took a very long time for them to be able to convince the staff that there was nothing wrong with them and that they should be released. In terms of symptoms, treatment, and culture, psychological disorders may not present in the same way across cultures, and a lack of understanding of cultural differences may lead to misdiagnosis as well. So for example, post-traumatic stress disorder, or PTSD, is a common psychological illness involving recurring thoughts, images, and nightmares associated with a traumatic event. It induces symptoms of tension and anxiety and can seriously interfere with many aspects of a person's life. So you've probably all heard of PTSD. Despite the seemingly universal cognitive symptoms of PTSD, research has found interesting differences in the cognitive and emotional symptoms. For example, recurrent personal flashbacks seem to be more common in individualistic cultures, while people from collectivist cultures reported recurring worries about the welfare of their families and communities. So we did see a few differences in terms of the exact symptoms being reported case by case and how they varied from culture to culture. And then finally for this section, we'll talk a bit about applications of psychological diagnosis. I mean, obviously, as I mentioned, I am cutting things out, so this module, you know, there is some stuff missing if you look in the textbook that I didn't really cover or I didn't spend much time on. But I did want to point out one particular application of psychological diagnosis, and that is the role it plays in the criminal justice system. So you've no doubt heard of trials where the defendant has pled not guilty by reason of insanity. In Canada, the insanity defense is now referred to as the mental disorder defense. It does not deny that the person committed the offense, but it claims that the defendant was in such an extreme abnormal state of mind when committing the crime that he or she could not discern that the actions were legally or morally wrong. So for example, being in a severely dissociated state, that might be characteristic of schizophrenia or another psychotic disorder, you might not actually literally be able to realize that what you're doing is wrong. You might not even be seeing things the way that they are. So despite common myths surrounding this mental disorder defense, it's extremely difficult to use, so it is used very infrequently. It's only reported in less than 1% of cases, and even when it is used, it's very rarely successful, so less than 25% success rate. So a lot of people think, oh, you know, people are going to use this and try to claim that they have mental illness to get out of the consequences of whatever actions they performed, but in reality, it's not something that's used very often because it is extremely hard to use and to argue for, and it is even harder to argue for successfully. So it's not something that would be used just out of desperation by a client. So that's the end of Module 1. I'm going to play this back now and take a listen to it, and hopefully it all sounds good. And then I'll post it for you. And so with the rest of the chapter, I'm hoping to get a big chunk, if not all of it, done tomorrow. So hopefully I'll have that posted maybe by tomorrow night. But if you do listen to this in the next 24 hours, please shoot me a message, let me know how it sounds, just to make sure it's actually working correctly and everything is kind of proceeding as it should. So thanks for listening, and I will not see you soon, but you'll hear from me soon.